Hello, my name is Dave Dixon. I'm professor and chair at VCU School of Pharmacy, and it's my pleasure today to be with you for this podcast entitled Evolving Standards in Familial Hypercholesterolemia, Innovations in Diagnosis and Therapeutic Strategies. This is a CME CE accredited episode of the National Lipid Association's Lipid Insights podcast series. This activity has been approved for AMA PRA Category 1 credit and is eligible for ACPE, ANCC, and CDR credit. CME CE credit is provided by the National Lipid Association, and please go to lipid.org/lipid insights to read complete accreditation details. Today, I am pleased to have quite a stellar group with us to discuss a published expert clinical consensus document from the National Lipid Association, providing an update on familial hypercholesterolemia. With us today, we have Dr. Ann Goldberg, who is a past president of the foundation of the NLA and current chief science officer of the NLA. She is a professor of medicine in the Division of Endocrinology, Metabolism, and Lipid Research Department of Medicine at Washington University School of Medicine in St. Louis, Missouri. Dr. Zahed Ahmad is the current secretary-treasurer of the NLA and an associate professor of internal medicine in the lipid section in the Division of Endocrinology at UT Southwestern Medical Center in Dallas, Texas. And last but not least, we have Dr. Joseph Sassine, who is past president of the NLA and a current professor and associate dean at the Skaggs School of Pharmacy and Pharmaceutical Sciences at the University of Colorado and to its medical campus in Aurora, Colorado. Welcome, everyone.
Thank you so much for having us.
Thank you, Dave. Pleasure to be here.
Thanks, Dave.
All right. So, familial hypercholesterolemia, incredibly important in lipid management. And while certainly the NLA has been a leader in providing guidance to clinicians on the diagnosis and management of this important condition, it is time for an update, for a refresh. And so what I'd like to do is kind of start big picture. And Dr. Ahmad, if you would, give us a sense of how paradigms in diagnosing familial hypercholesterolemia have evolved over the last decade.
Yeah, this is a very important question. If you read the literature, you will see people talk about these scoring systems like MedPed or the Dutch Lipid Clinic Network or Simon Broom. And those are great. It can give us some context and some way to objectify the diagnosis. But what we learned and what we recommend is that you don't necessarily need to use these scoring systems. And it may not be practical. If you're in the room with a patient, you're not going to pull up your phone with its MedCalc and put in all the numbers. It takes too much time. It's too difficult. So we think it's totally fine if you have any experience diagnosing FH that you can just rely on some generally accepted standards. The person has very, very high cholesterol. They have either a personal or a family history of premature cardiovascular disease, or even a family history of very high cholesterol. And that's really sufficient to justify a diagnosis. And the reason we think that's important is because these individuals, regardless of whether they meet some criteria that we come up with, they deserve aggressive treatment, and they do not deserve getting their medications rejected by insurance because they don't have enough points on some system. And the other thing I will say, the other important thing is that the ICD-10 codes have changed. So this is a very important point that we wanted to get out there, that this will, now we have more specific codes for homozygous FH versus heterozygous FH. So we do hope that people use these. These can kind of help us track outcomes over time. But that's kind of a gist of how things have changed in terms of diagnosing FH.
So one thing I heard you say is very high cholesterol levels. So give our listeners a sense of what LDL cholesterol level should be an indicator that the patient is likely to have FH.
So the cutoff we typically use is an LDL of 190. This is not a hard and fast cutoff. There are people with lower LDLs who do have FH. but the vast majority of FH patients will have an LDL well above 200. And uh, that correlates very well if you try to do genetic testing and identify people who have very high cholesterol. So that's kind of the cutoff we use uh, for when we say it's severe hypercholesterolemia. The other thing I will say is that when you do see someone with that high cholesterol, make sure you do rule out other causes. That is part of the diagnosis too. Make sure it's not nephrotic syndrome or hypothyroidism or the patient doesn't have cholestasis. Once you rule those things out, the chance of it being FH is much higher.
Another thing that we want to think about with the secondary causes is medication. So, Dr. Sassine, you want to give us a brief list of medications that our listeners should look out for as potential secondary causes?
There are always a list of medications that can change lipid parameters. Many of them that we use that are common have result in small changes in total cholesterol. Sometimes you can see more on the triglyceride end. So for the focus of today, really looking at FH, unless a drug is inducing hepatotoxicity, significant hepatotoxicity, the changes in LDL usually are not very robust. So we may think of some antihypertensives, such as thiazide diuretics, beta blockers, which traditionally have been associated with small lipid changes. As far as, though, for the rule out of extreme elevations in LDL cholesterol, most of those are really not of concern in our patients that we're suspecting FH.
Great.
I will say one thing to always sort of consider, though, is the influence of alcohol, again, more with triglycerides, since alcohol is considered a medication or a drug, I would say.
Excellent. So we know that FH is on a continuum and that we have two primary types, so heterozygous FH, homozygous FH, and the epi data in terms of the prevalence of both has really evolved in recent years. And of course, part of that diagnostic workup, which then kind of helps determine prevalence, relies heavily on the clinical presentation and what that looks like. So, Dr. Goldberg, could you give us a rundown of the differences between heterozygous FH and homozygous FH?
Sure. So when you think about FH, familial hypercholesterolemia, you're thinking about a genetic disorder, and there is a high prevalence of heterozygous FH. Heterozygous FH involves one allele being abnormal in one of four genes, LDL receptor gene, the gene for apolipoprotein B, PCSK9, gain of function mutations, and there's an autosomal recessive LDL receptor adapter protein 1. So a single mutation leads to basically about half the normal number of LDL receptors and LDL levels that range generally from 160 up to about 400. Typically, the prevalence of this is about 1 in 300 now. We know people used to say it was 1 in 500, but that actually, it's much more common than we used to think even. So it's not a rare disorder. It may just show up with a high LDL level. On the other hand, those people who are at the higher end of the LDL levels can show up with different kinds of physical findings. Corneal arcus. So early corneal arcus, a complete ring around the edge of the iris, a grayish-white ring, before the age of 40-45 is very suggestive of FH, since FH, basically the high LDL levels start at birth, and there's a cumulative effect. The other thing that's an important physical finding are tendon xanthomas, typically the Achilles tendon, the MCP tendons, but also sometimes tibial tendons over the elbows. Those tend to be more seen in people as they get older who are at the higher end of the LDL levels. These are quite variable. Homozygous FH involves two mutations, so it's biallelic. So it's either mutations in two LDL receptor mutations, or combinations. And these levels start at LDLs of usually about 400 to 500 and above. And they go up into the range of LDLs that can get up into the 900, 1000 milligram per deciliter level. These people show up in childhood typically, although not always well recognized. But one of the classic findings are planar xanthomas, flat, yellowish plaques occurring in the antecubital fossa, over the knees, over the buttocks. These may show up early on. Children may show up with tendon xanthomas before the age of 10. That's kind of a classic clinical finding. And again, this is used to be considered extremely rare, about 1 in a million, but actually the overall prevalence is probably about 1 in 250 to 300,000 when you actually do a lot of testing of populations.
Are there certain population groups that carry a higher risk for FH?
Yes, so there are founder effects. And so when you, populations that tend to have a rather closed group, such as French Canadian population, Northern European Jewish populations, very classically, it was the Lebanese Christian population, so Lebanon, Syria, and then three rather closed populations in South Africa related to actually apartheid, such that there's a very high prevalence of familial hypercholesterolemia and homozygous FH in South Africa. So these populations have much higher prevalence of homozygous FH. The prevalence of heterozygous FH may be 1 in 100, and very much higher homozygous FH prevalence.
So given that we understand that FH is a genetic disorder and it is a major leading cause of premature atherosclerosis and premature cardiovascular death, why are screening rates in children so low?
Well, there are a number of reasons. First of all, I think that there's a lack of perception of how common FH is. Another issue is just the logistics of getting blood drawn. If you say you always need a fasting level, and the child is not fasting, then the family leaves and the levels never get done. So non-fasting levels can be done, and actually screening is almost easily accomplished by point of care testing in a pediatrician or family practitioner's office. There may also be reluctance of various clinicians to screen because they are not convinced that they want to be treating children, or they're not comfortable treating children. And there actually have been groups that have come out saying that we should not be doing screening of children, and that you should only screen children who come from families where there's a very high risk of atherosclerosis, strong family history. The problem with that is that with young parents, there may not be any evident events. There may not be heart attacks and stroke if the parents are in their 30s or 40s. And unless you take a careful history and ask about grandparents, you're not going to get that history. So there are a variety of factors: logistics, reluctance on the part of parents, reluctance on the part of clinicians to actually do the screening, as well as the fact that even though this has been recommended since 2011 by the American Academy of Physicians and the NHLBI, it takes a very long time for guidelines to be disseminated. Pediatricians and family practitioners have a huge amount of things to do in oftentimes short office visits, and screening for cholesterol levels just doesn't always come to the top of this in kids who have no other risk factors.
So, Dr. Ahmad, given what Dr. Goldberg just outlined, what strategies could healthcare teams adopt to improve early identification and cascade screening across families?
Yes, that's a very important question because it's not on the top of any healthcare administrator's mind. Before I answer that, I do want to point out something, that homozygous FH is nature's experiment on what happens if you are just born with pure elevated cholesterol, extremely elevated cholesterol, right? And I say this because there is a movement that is growing now about cholesterol is not bad for you, that higher cholesterol levels are better for you. They talk about oxidized LDL. They talk about cholesterol is not the important point, the important factor. It's actually inflammation or insulin resistance. But to those people, I would say read up about homozygous FH. This is nature's experiment. It's a cruel, unfortunate experiment, but it is. You can be born with such severe high cholesterol that you can have cardiovascular disease by age 5. There's no inflammation. There's no small particle sizes. There's nothing else. It's not an issue of oxidized versus oxidized. It's not insulin resistance. It's just purely high cholesterol. And so I just wanted to put that out there because that unfortunately is something we deal with in clinic every day now. Patients come in with these questions. In terms of your actual question, I apologize for going on a tangent. I go on that tangent every day almost now. But in terms of your question, obviously we talked about pediatric screening. We acknowledge that there was a recent manuscript in a high impact journal that showed that pediatric screening may not be cost effective. But seatbelts are not cost effective. Many things are not cost effective. That's not the issue. The issue is what benefit can we do to society? You can't really put a cost on that, right? Certainly cascade screening, if a healthcare system could figure out how to do it, would be cost effective. In fact, it even is cost savings if you can do it with less administrators. So that's another strategy. If a healthcare team could figure out how to do that in a reasonable way, that could help early identification and screening. The other thing that our institution and many institutions have done is just a simple algorithmic flagging. You can get very simple or very complex with this. The simplest thing is if someone ever has an LDL above 190, it gets flagged and somebody reviews it. And if they need to see a specialist, or if their primary care doctor just needs to see the words familial hypercholesterolemia in a MyChart message or some kind of communication, that can help. That does help downstream. Or there's much more sophisticated machine learning algorithms that take much more into account than an LDL level. And they also work. They can identify patients. And so these are some of the things that certainly a healthcare team could implement or a healthcare system could implement.
So thank you for that. And I think we now have a really good foundation and background on familial hypercholesterolemia, prevalence, the underdiagnosis that exists. And so what I'd like to do now is dive in a little bit more into the role of genetics and imaging and other types of diagnostic considerations as it relates to FH. So, Dr. Goldberg, how has the role of genetic testing in FH expanded beyond confirming a diagnosis?
I think that FH genetic testing has really come a long way. And for some years ago, it was expensive and difficult, required a lot of effort to get testing done. And only 4 genes were tested. There were not as many mutations known about, so there were many negative test results. Genetic testing has now expanded to include all the 4 major genes, plus some other phenocopies and areas where there may be some overlap. The other issue is that the genetics is not as simple as we used to think. And so there may be differences between what turns up in the genetic test and the LDL levels, for example. For example, if someone inherits an LDL receptor mutation, but also inherits a mutation in, say, NPC1L1, which decreases LDL, then that's going to affect the levels. Genetic testing has become easier to get. More people know about it, and I think that it has made a big difference. It does help in terms of cascade testing. So if you find a mutation, you can then go on to test other family members.
So another aspect of the genetic testing that comes up often in practice is you order the genetic test, you suspect FH, and the test comes back essentially negative. Tell our listeners a little bit about how they should approach that and what that may mean.
So there are many mutations known. The problem is that you can get mutations of unknown significance where there's not a large enough data set to figure this out. And there can also be people who are phenotypically very clearly have FH and have a negative genetic test. And a negative genetic test should not change the diagnosis. The diagnosis should continue to be made on clinical grounds. One of the things that genetic testing can help with is it can identify people who say, yes, this person clearly has FH. This person clearly should qualify for various medications. And that has been particularly helpful in homozygous FH. The problem is that it's not a perfect system. It is not 100% sensitive. So that is an issue. So a negative genetic test does not exclude the diagnosis of either heterozygous or homozygous FH. And that needs to be very clearly kept in mind. The other thing that can be helpful with genetic testing is if you do get a mutation, this can be very helpful in discussions with families. And it helps families in that they can then feel, okay, this is not my fault. This is a genetic condition. And also make people realize that since it is a genetic condition, it's not going to just change with weight loss, diet, exercise, that it will require treatment with medication. So I think that's also been very helpful. For homozygous FH, it clearly means that you have to look at both sides of the family in most cases, almost all cases, and that this expands the cascade screening that needs to be done. It also helps inform the family of what you need to look at over time. So I think it can be extremely useful, but it is not mandatory.
So I want to bring in Dr. Sassine here, and I think, as Dr. Goldberg outlined, the utility of genetic testing. Can you help our listeners understand how those genetic testing results could help stratify risk and help inform decision-making around pharmacotherapy?
Yes, I think it's a great question. I think I sort of have a prelude that we're seeing a lot of large health systems, especially the academic medical centers, offering biobanks and offering genetic screening for a variety of different things. Those broad screenings sometimes do include everything from drug metabolism, mutations, and different variants. But also we're seeing more that include things like LDL receptor variants. And they don't always cover everything that you might want to know from a lipidology standpoint. So that's my prelude, is that we're seeing a lot of this. The catch is, absent homozygous FH, that there's not an essential need to do genetic testing to predict drug response. But there is, in my opinion, in working out of primary care, a lot of things that we can learn from what we know. And there's sort of three elements of genetic testing that give us insight to drug development. And in some patients may, I don't want to say predict the response, but explain their response. So we know that there's been a lot of science looking at PCSK loss of function variants and even gain of function variants. Patients who have this loss of function variants really gave us some good evidence that we should look into why PCSK9 may be a viable biotarget for drug development. That sort of led to the onslaught of the monoclonal antibodies. And similarly, I guess the other side of that coin, patients with PCSK9 gain of function variants, we've seen that these patients do have changes in LDL-cholesterol that open the door for science. But in our patients with FH, there's a variety of different genotypes that patients can have. And for patients that have a single heterozygous LDL receptor or ApoB mutation, they typically exhibit, you may read in the literature, a robust LDL reduction of 60% with monoclonal antibodies that target PCSK9. And that's great. That's probably sort of what we would expect in our heterozygous FH patient, a good response from a PCSK9 monoclonal antibody. But we also have patients, which has been alluded to, that have this compound or homozygous LDL receptor or ApoB mutation that can be carriers and have that full response. That full background, I guess, is from a genetic profile. And these are the patients that when they go on PCSK9 drugs that have a minimal response. And it doesn't mean it's zero response. but it's not going to be the 60% reduction that we see in the single heterozygous LDL receptor ApoB mutations. These patients may experience in the 20%. I think from the perspective of what a clinician would do, I think if you have a homozygous FH patient, those patients should be cared for by a legitimate certified clinical lipid specialist, a lipidologist, to offer all the therapeutic options possible. But for our routine patient where we may suspect heterozygous FH or just severe primary hypercholesterolemia, their LDL is 190 or higher, I think it's not necessary to really fully flesh out their genetic background and look for these variants, because sometimes our experiment is, do they get a typical response from our medicines? And if you have a patient who has a very blunted response, it's probably going to fall into that patient population as the compound homozygous LDL receptor ApoB mutation by being a carrier, having that full genetic background. So that's probably what we know the best. There's some other things that people dive into, looking at safety and looking at genetic testing for safety, or even predicting long-term side effects, such as an increased risk of new onset diabetes or higher BMI values. I think that's a little bit more not ready for prime time. And it's nice to know. I think the safety aspect, I think it's sort of dead, because there's really no reason to do that unless we use monoclonal antibodies, which are humanized. But the monoclonal antibodies that we have for PCSK9 are fully human monoclonal antibodies, and really make any genetic testing for things like the HLA variants sort of meaningless. And I guess if you're interested in that at all, we used to have a PCSK9 monoclonal antibody called bocicizumab. It was not fully human. It was humanized, which means a higher degree of immunogenicity, and patients can develop anti-drug antibodies. We're well beyond that. So that historically is in the literature, but sort of gone. So I guess my bottom line is there's some really intriguing things, and it's a little bit more in the homozygous population where you get a blunted response. I think my last comment, and I'd welcome some other ones from our other panelists, is even if you get a 20 to 30% reduction in LDL cholesterol with a monoclonal antibody, if it's a homozygous FH patient, I think a lot of clinicians would still continue that therapy. And I'd welcome some input from Dr. Goldberg, Dr. Ahmad on that.
I would, one of the things I would say about the homozygous FH patients, that the genetic testing, if you do a deep dive and look at what variants you have, it will sometimes tell you. So the people who respond very poorly to standard therapy are people who have null. That is, they have no LDL receptor activity at all. The people who have some receptor activity, the defective or null defective or just too defective mutations, will have more of a response. And so you basically try everything. And you can sometimes get the sense of this when you have, say, a mutation in the LDL receptor and they are both complete early stop codons, so that there's basically no protein formed. And two of those are often not, completely null. That isn't to say they won't respond to regular therapy to some extent, but that does sort of, when you look at that carefully with the individual, you can sometimes get a feeling for, yes, now I understand why the numbers are so high. Now I understand sort of what the partial response means to the multiple therapies.
All right, so such a great discussion of genetic testing, and I think that the key takeaway here is that genetic testing for FH matters. That it certainly has a role. It's important in terms of helping with risk stratification, but is increasingly becoming a tool that we can use to inform therapeutic decisions as well. But in addition to genetic testing, imaging modalities such as coronary artery calcium scoring and CCTA are increasingly being used in preventive cardiology practice and lipid practice. Dr. Ahmad, what are some of the advantages and limitations of using those modalities in the management of patients with FH?
Yeah, this is an important question. And let me start with coronary artery calcium scoring, which is becoming more and more common and quite cheap. I mean, there are places around Dallas where I practice that do it for $80. And it's typically a cash thing in Texas because insurance doesn't cover it, but the $80 is pretty reasonable. The main use of coronary calcium is risk stratification in an asymptomatic patient. It's not used to rule out cardiovascular disease or coronary disease. Uh, and so for FH, the exact role is unclear, but people who do coronary calcium scanning often talk about the power of zero, meaning that if your score is zero, your chance of cardiovascular disease, at least in the next 5 years, is extremely low. That's not doesn't really apply to FH. Maybe you could argue that it's a 4-year type of thing, 3 or 4 years, you won't have a cardiovascular disease, but it does not rule out any cardiovascular disease or coronary disease in individuals with FH. And so it might be useful in a younger person if the calcium score is above zero. If it's not zero, then you might intensify therapy earlier rather than later or something like that. But that's kind of the main thing. I think the most important thing with coronary calcium is that the absence of calcium does not mean plaque is absent in an FH patient. Typically in an FH patient, plaque will develop 10 years before it gets calcified. And so that then brings me to the other test, the CCTA, or cardiac CT angiography, which is more comprehensive and identifies non-calcified plaque. And like I said, that can appear a decade before the calcified plaque does. It's mostly useful in people who are having symptoms of coronary disease, so chest pain, etc., shortness of breath. That's probably the most validated use of it, but you can also use it in other ways. Sometimes we use it in people who have a lot of high risk features to understand if they have a plaque burden right now. So somebody, like we just talked about, null mutations. So if you have somebody who's homozygous FH with null mutations, you might do a cardiac CT angiography earlier in life than you would otherwise. Or somebody has very strong family history, or they've been exposed for a very long time to very high levels of cholesterol, like almost every FH patient has. And in homozygous FH, you can consider doing it much, much earlier in life. But there are still limitations. Uh, you know, it does involve injecting dye. There's some risk to that, not much. It is a little bit longer procedure, so you do have to stick around for a while. Your heart rate ideally would be, I believe, less than 70 or less than 60 so that they can capture good images. So you might need to take a beta blocker or something like that. But that's kind of the overall picture with these imaging tools. They have a role, but most of the role should be limited to intensifying therapy earlier in life if somebody has some identifiable plaque.
I would also add that there's certain guidelines are now recommending that when you diagnose homozygous FH, that probably a CCTA would be recommended at the time of diagnosis, because in some cases, depending on when you diagnose homozygous FH, you may already have significant coronary artery disease in that child, adolescent, or young adult. And it's useful to know whether that's there or not in terms of the person who presents with homozygous FH.
So certainly the diagnosis, workup, and management of FH is complex and is increasingly relying on the entire care team and multiple individuals to provide care for these patients. So, Dr. Ahmad, how can genetic counselors, lipid specialists, cardiologists, and other clinicians collaborate more effectively to provide more comprehensive care for patients with FH?
Yes. So these individuals often do take a whole team to help out. For example, if you do genetic testing, there is a chance that you get a variant of unknown significance. And that's where a genetic counselor may help out. Now, in our clinic, I kind of do our own genetic counseling, but that's because I have experience from research studies doing that. I wouldn't recommend it to everyone, but if you do feel comfortable, I look at the variant of unknown significance myself. I read what the report says about it, and sometimes it's a VUS, a variant of unknown significance, only because it's never been seen before. All of the other characteristics of that particular mutation or that variant point towards pathogenicity. So in such a case, that's where family screening actually helps quite a bit to see if that particular VUS segregates with the phenotype, meaning does everyone who has high cholesterol also have that variant, and everyone who does not have high cholesterol does not have that variant? That can help you understand things. So that's where a genetic counselor, if you're not comfortable doing these things, that's where a genetic counselor can help. We do write in our manuscript that for the average patient, you might not need a genetic counselor. If you are comfortable explaining what genetic testing is, in other words, doing the pre-test counseling, and after you see the results, if you're comfortable explaining what the results are, then you don't necessarily need a genetic counselor. And that's based upon guidelines written by genetic counselors, that FH is a condition where many cases can benefit from just brief counseling and don't always need a genetic counselor. Genetic counselors also are pretty good at helping out with the psychosocial dynamics of cascade screening and things like that. It is not, every family talks about health differently. Yesterday, I saw a patient who clearly had FH, and he was actually the oldest living person in his family at 67. Everyone else died in their 40s or 50s. And he says that every time their family gets together, all they talk about is their cholesterol and how many people have cardiovascular disease. As opposed to some of the other families we run into, where people say they never talk about their health issues. Or some other families where people said that, yeah, my family did talk about health issues, but when we were kids, they would make us leave the room. We weren't allowed to listen in. And that has an impact when they're adults. They don't know all of the family history. So every family is a little different. It takes a little bit of experience to understand how to talk to people about their results and how to tell them to tell their family about the results. And so that's where genetic counselors help. Lipid specialists and cardiologists collaborate, many times, especially if the patient has cardiovascular disease. They probably need a cardiologist who has some experience with interventions and whatnot. And oftentimes it takes a team to get the LDL below 55 if that's a target for that particular person. So that's kind of the ways that we can all collaborate and provide comprehensive care.
Thank you for that. It definitely takes a village. And I think that's also a good segue into our final section here, because one of the key areas that has evolved greatly in recent years and continues to rapidly evolve relates to the therapeutic landscape and the availability of a wide range of lipid-lowering strategies that we now have at our disposal. So I'd like to start off with Dr. Sassine and having you tell our listeners what current first and second line treatments for FHR and how should clinicians approach deciding when to utilize combination therapy.
Well, I think there's a real easy answer to this. For most of your patients with FH, which I'm going to bucket in as either having severe primary hypercholesterolemia or heterozygous FH. Nothing's really changed for first-line therapy. We start with statin treatment. And there's other second-line agents, which are LDL-lowering therapies for the majority of our patients with FH, which includes everything from ezetimibe to the PCSK9 inhibitors to bempedoic acid and some newer therapeutic agents that can be added to that treatment. I think that the fundamental thing that we should keep in mind is it is extremely important to at least, at minimum, cut the LDL by 50%. But in this population, that might not be good enough, depending on how high they are. I think you always want to get, regardless of risk, you want to get the LDL, if possible, into the double digits, not the triple digits, down to the double digits. And that, for the majority of these patients, can require much more than a 50% reduction. So if you are, you can use normal logic with statins and our oral agents and even the PCSK9 monoclonal antibodies and even inclisiran and lorladelcibep, that if you need much more than 50%, you really should consider initial combination therapy. For our homozygous FH patient, while perhaps not the first line treatment, there are some unique therapies like lamidipide and evinacumab, which are uniquely approved for homozygous FH. Evinacumab may have some significant advantages in your patients that have problems with their LDL receptors based on their genetic profile because it is a mechanism that's independent of the LDL receptor. So bottom line, in summary, we still have our same list of first and second line agents that we have for all forms of hypercholesterolemia apply to our patients with FH, especially those with heterozygous FH.
Dr.
So
Singh,
in regard,
can I ask a question real quickly to you?
Sure.
First line is clear. Obviously, if we can use statins, that's the best option. They work in heterozygous FH. What about second line? Because I was just giving a talk to our APP team at our county hospital about starting to use PCSK9 inhibitors. Finally, even though they've been out for 10 years, they finally opened it up so that anyone in the hospital system can use them. But they still have an attitude that they have to use ezetimibe first. And they looked up, while I was talking to them, they looked up the Medicaid requirements, which seem to indicate that you have to use ezetimibe after a statin before you can use a PCSK9 inhibitor. What are your thoughts about that?
Yeah, this might tie into a follow-up question that we have on this too. But that's a very clinically relevant question. I think that economically, nothing's going to beat ezetimibe. Ezetimibe is just about free. Statins actually are just about free too, as far as drug costs. So it's hard to not consider using them. But you have to understand what they can provide. Statins can give you 50+% reduction if you use the right one. Ezetimibe, I just say it adds an extra 20% reduction. And that's often not going to be enough for your patient, depending on how far. So I think we have to maybe even lean into some of the other publications that were beyond the 2018 guidelines. And the expert consensus by ACC does open the door that you should consider how much reduction you need in LDL cholesterol. And if you need more than a 20% reduction and somebody's already on a statin-based regimen, the maximally tolerated dose, you can add ezetimibe, but you're not going to get to your therapeutic objective. And our paper does outline all the goals depending on your patient. Every single goal that's recommended for LDL cholesterol is in the double digits, meaning at least less than 100, but can it go down further, down to beyond our American recommendations into some other guidelines from across the world that in some patients you may target not just less than 70, not just less than 55, but even lower depending on their risk profile. So I think we have to be smart about that. We're going to see, and we can probably come back to this point, that restrictions by our insurers, whether it's Medicaid or commercial insurance, often still does have that step therapy of ezetimibe. I'm experiencing less of that. It's not gone, but there's less of that than there has been traditionally over the past previous years. But for these patients, especially those with FH, we really need to lean into everything that's been stated on this podcast earlier, that these patients are different. Their elevated profile. I love Nature's experiment with the bad experience of what happens with your risk of cardiovascular disease with homozygous FH, and it is early heart disease. So we really need to sort of appreciate that in this population, the risk of progression is much different than in somebody without FH. And so there's even more of a reason to not wait as much as you might with another patient. And so pick your regimen and what will get to your therapeutic objective in the first step.
Yeah.
And I think that's
Dr.
why
Dixon,
we're sort of escalating that more.
Yeah, sorry, Dr. Dixon. I didn't mean to take over your role as the moderator and ask a question. But my other point to the APP team was that in the clinical trials, there was no requirement that the patient had to be on ezetimibe before getting a PCSK9 inhibitor. And it's not in the FDA indication for PCSK9 inhibitors as well. It's purely just for cost.
Yeah, the FDA, and if you really want to open your eyes, look at the indications for the monoclonal antibodies. They're very broad, and they've been rewritten recently to be extremely broad, not to be as addition always to statin-based therapy, even though I endorse that. They're very broad, and you can look at the FDA label, and it will say monotherapy. You can start as the first drug. Insurers don't always think that way, and I'm frustrated to say that, but it's the truth.
I would add, however, I'd just like to make the point that patients sometimes stop taking their statin and or ezetimibe when they go on a monoclonal antibody, and then they're disappointed in the results. The triple drug therapy can make a big difference. And if the monoclonal antibody by itself is not enough, then ezetimibe, some dose of statin, if they're not able to take a high dose statin, is really important. And so emphasizing that we really need multiple drugs to treat some patients with FH to get them to goal is really important. And the other thing that should be brought up is that it doesn't really matter if the LDL gets really low. When the LDL gets really low, that is not a reason to start backing down on the other medications.
Hallelujah, because I still get the question, how low is too low? Is there harm with my LDLs in the 30s? And that's a very common question that we have a whole bunch of information to rebut. And in this population, if you have a primary prevention patient whose baseline LDL was, I don't know, in the low 100s, do they need to be treated to an LDL of 20? No, they don't. But we certainly shouldn't fear it, especially in the FH population.
So great discussion about the therapeutic options. And so I'm hearing that certainly statin therapy remains first line. And then in terms of second line therapies for FH, the majority of these patients are going to require at least a second and potentially a third agent to reach some of the lower goals that are now being set by some of our guidelines. And we've talked on the role of PCSK9 directed therapies, which continue to expand. Just recently, a third generation PCSK9 therapy was approved by the FDA. One newer therapy that we haven't touched on yet is bempedoic acid. So where does bempedoic acid fit into the treatment sequencing for FH patients? Where do you see that being a good fit?
Well, I'll start off this, and I'm sure other people have comments. I think when you're thinking of an oral option, and it's beyond statins and ezetimibe, I think bempedoic acid is an excellent drug to consider. I think you have to sort of accept what it is. It is a drug that's going to give you as much LDL lowering as ezetimibe. So if you do use bempedoic acid, I always emphasize I would prefer the patient also be on ezetimibe in combination with bempedoic acid, just to give it a little bit more efficacy and let it go to the high 30%. So I think it's a consideration in your patient when you're looking for an oral option, or if you're very close to your therapeutic target. It's hard to discount the power in LDL lowering of a high-intensity statin and in the PCSK9 blockers. PCSK9 inhibitors, that's what I holistically call the all generations of PCSK9 drugs, which include the monoclonal antibodies that we have available, inclisiran, which is a small interferon RNA therapy, and lorudalsibep, which is, as you mentioned, the third generation protein that is adenectin-based protein that reduces LDL cholesterol by binding PCSK9. Those just provide so much reduction in LDL cholesterol, we can't not think of them. But I think with oral therapies in patients who do not have a history of gout, I think bempedoic acid can provide some respectable reduction in LDL cholesterol.
And as we all know, not all patients are open to injectable therapies, but certainly in my own practice over the past couple of decades have seen that patients are more and more open to considering injectable therapies, but it is nice to continue to have oral options for patients. So Dr. Ahmad, we have a number of treatment options, and we know that there are some differences in how we might approach treating patients that have heterozygous versus homozygous FH. So are there any key differences in how we might use these therapies in these two groups, or does it matter?
It does matter, and I believe we've discussed it a few times now. For heterozygous FH, they respond quite well to the usual sequence of cholesterol medications that we use. But homozygous FH is a different thing at all, a different thing to approach. Most of the traditional cholesterol drugs we have rely on the LDL receptor. And if you're null or you have two defective copies of the LDL receptor, it becomes very hard to lower cholesterol beyond just reducing cholesterol synthesis a little bit or reducing cholesterol absorption from the diet a little bit. And so people with homozygous FH require these LDL receptor independent pathways or drugs that target those pathways to reduce cholesterol. And the two drugs that are used commonly nowadays are limidopide and evinacumab for people who have homozygous FH. And the other difference for homozygous FH is that, with heterozygous FH, we might be patient and wait a little while, especially if we start at a young age. Homozygous FH, you're not patient. You escalate therapy quickly because these people have been exposed to so much cholesterol. They need to get their cholesterol down as quick as possible, and we quickly get them to multi-drug therapy, and then LDL apheresis if they need it.
Absolutely. So we've gone through a number of therapeutic options, but at the end of the day, it is all about how we implement them, right? So we have to actually get these medications in the hands of our patients. So Dr. Sassine, what are some practical challenges that healthcare teams face when trying to optimize lipid-lowering therapy, whether it be related to medication cost, adherence, concerns regarding side effects, or as we've already alluded to, the joys of managing prior authorization issues?
I think the biggest challenge is access, and access can be strained by these factors. One thing that strains access is adherence, patient adherence. And adherence can go down for a variety of reasons. It could be because of experienced side effects, perceived side effects, or cost of therapy. So they all sort of relate to the same thing. But adherence, when I say it, is a very complicated, multifaceted problem and barrier. I think that's probably the biggest issue. And things that were mentioned here that that apply to the FH population, apply to any of our hypercholesterolemic patients, that we have mis and disinformation about cholesterol. Even some of our younger patients that never had a cholesterol abnormality and their LDL's gone up and they're on anabolic steroids or something like that might explain it. We sometimes get the pushback that, well, a little bit of increase in my cholesterol doesn't make a difference, and I heard that it's good based on this blog or this podcast. So we're often faced with dispelling and misinformation. There are patients that do have real side effects. I think that this is mostly highlighted with our statin treatments, as we all know, because of the stigma that some patients have, or sort of the banter that they have against statins, the defiance that they issue, and that requires a different approach and sort of dispelling those myths and trying to helping people see the truth. And of course, I don't know how much I could say good and bad about access related to cost, because these, when we go beyond ezetimibe and statin therapy, we do have brand name only medicines that can be costly. And we do have policies and stepped care that don't always reflect the science as they should, but are focused in on cost conscious approaches. So those are the biggest challenges that I see.
So I want to open this up to all of you to kind of reflect back on your own practice, and if you would share some strategies that you have found to be effective in helping you overcome some of the challenges that Dr. Sassine laid out.
I'll start off a little bit just by promoting something that's already been mentioned, which is a team-based approach to care. I know it's easy to say that not all clinic situations can have a team-based approach. So ideally, if you have more than one professional helping patients in their treatment journey, that is beneficial. Even if it's just hearing another perspective from the medical provider, can actually really lean into the diagnosis and overall treatment direction. And pharmacists, nurses, other allied health professionals really can help get people to the goals and optimize medication therapy. I think that team-based approach, or leaning into other resources, sometimes they may not be within your building. Sometimes they may be the pharmacist where the patient's getting the drug from, to actually speak in patient language to help them really feel like they understand their treatment plan. Engaging patients in some of the choice. I know there's a very strong push for shared decision making. I'm a believer of that. It doesn't mean that the patient, tells you everything that's going to happen. It means that you help guide the patient to make appropriate choices, and that they have a stake in the treatment plan because they feel like they can control some of it, and because ultimately they're going to be the ones who control their treatment plan when they go home. I think that's helpful. And the last thing that I think is really an issue when we go beyond statins and ezetimibe is having some kind of dedicated resources to help with access, whether it's a medical assistant team, a nurse, a pharmacist, people that can deal with those prior authorizations. And if there's any good in some of the newer therapies beyond lipid disorders going more into the cardiometabolic space, we have a high demand for GLP-1s. And some of the people that are really good at getting access to GLP-1s can get access to our lipid-lowering medicines too. It's the same kind of skill set, but we don't often invest in those people and give them that job scope to actually become really proficient in that area. So I think that's an ideal situation. I do realize that not everybody lives in the ideal world.
I will add a soapbox that I've been on, and I can't speak as eloquently as Dr. Sassine just did, but a soapbox that I've been on is we need to get people to prescribe more PCSK9 inhibitors. You know, there's data, it's a little old, but there's data from claims databases showing that of all people with the ICD-10 code for FH, 3% are on a PCSK9 inhibitor. That's unbelievably low. It's impossible that only 3% of FH patients require a PCSK9 inhibitor. So I've been telling people, go ahead and prescribe it. You're not going to waste money because nobody's prescribing it. We need to get it out there more. And I think that, this is my personal opinion, I think that the reason why it's not prescribed more often is negative stigma. People still have an attitude that it is hard to get or hard to take. And when I show people the pen and they cannot believe how easy it is, maybe it's not as easy as some of the incretin therapy pens, but it's almost as easy. And I show them that, look, yeah, fine, you might have to do a prior authorization, but nowadays they tend to get approved. It's cheaper than it used to be. It's much easier than it used to be. That we need to move past the stigma that it's a hard drug to get.
I think that also, with some of the newer therapies, particularly larodalcibep, which is not yet available, with being once-a-month therapy, and possibly lower cost may be helpful. I also tend to use inclisiran because of its pricing model in my patients who are on Medicare. And that's only once every 6 months after the first 2 doses, given in an infusion center or in a physician office. So then you avoid even that whole issue of self-administration. I agree with that you need kind of a bulldog person dealing with a prior authorization, like never give up, never surrender, and just keep pushing when there's pushback.
I want to emphasize that point so much because we should never give up if there's one refusal, because one refusal often happens, but it's that second request that often is successful if you're trained appropriately and say the right things in the prior authorizations.
And also, in addition, using the diagnosis codes, the new diagnosis codes are really helpful. I think that is something that probably does make a difference.
Terrific points. So, in summary, certainly it takes a village, it takes a team. I think there are a lot of process-oriented barriers that, as you all alluded to, require individuals that can really spend the time to help kind of navigate those. And at the end of the day, it's about doing what's needed for our patients. So thank you for those comments. And our last question here, I want Dr. Goldberg to close us out, because we've talked about a number of drug therapies that are available, but the pipeline is still rich with emerging therapies. So are there any new therapies or recent indications related to the management of patients with FH that our listeners should be aware of?
Well, I think I want to just, we'll mention larodalcibep once again as being another PCSK9 inhibitor. But in fact, an oral PCSK9 inhibitor is in development and hopefully will be coming out within a year or so. And that's encyclotide, which is given a daily and that PCSK9 inhibitor, which is very effective and should also probably help as well for the people who are averse to injectables. Evinacumab is an ANGPTL3 inhibitor that's a monoclonal antibody that's infused IV once a month. There also is an siRNA ANGPTL3 inhibitor in development that would look particularly useful as well in homozygous FH, since the mechanism of that drug really does not need LDL receptors. So those are a couple things that are in the pipeline. The other thing we should probably mention is when you add high levels of LPLA to FH, that markedly increases people's risk, and there are a bunch of LPLA therapeutics in development, and hopefully will be coming out in the next within the next year.
Fantastic. Well, I want to thank Drs. Goldberg, Ahmad, and Dr. Sassine for joining us today and sharing their insights and some of the details for the expert clinical consensus that they developed on familial hypercholesterolemia. Congratulations to you and the writing committee on a terrific paper that I think will have an incredible impact. I also want to thank our listeners, and we hope that you enjoyed this discussion. You may claim CME CE credit by visiting lipid.org/lipid insights. For questions regarding CME CE credit, please email cme@lipid.org. Thank you.